clusters under control, they've been creative. And so there is no one size fits all, no one solution to how to do this, how to implement this. But we are seeing countries that are being very creative. And I want to bring young people into this because we are seeing that there is a little bit of a shift right now in the number of cases that we are seeing in younger age groups. Mm-hmm. And I think this is being driven by the fact that some societies are opening up and many people are going about their lives, and younger adults are going about their lives, and they're coming into contact with others. We've seen outbreaks in nightclubs and in entertainment types of situations, and we're seeing younger people get infected. And so everybody has a role to play. So if you are participating and you can, participate in contact tracing, if you feel comfortable using that app, if you have that trust, do that, and that can help us. But everybody has a role to play.
Thank you very much, Maria. Our viewers are asking a lot of follow-up questions, so I'll try to pass some of those now. One is coming from our Periscope viewer. Why do some countries show very low death rates after the first wave of COVID-19? Are there any linkages to the tools you just mentioned, that if we test and isolate contacts earlier, that we can also treat patients better?
Yes, so there's a couple of reasons, I think, why we see differences in mortality rates across different countries. First of all, in some countries, the virus has caused outbreaks in younger age groups. So I give the example of the Republic of Korea and South Korea, where initially they had outbreaks among religious groups and churches, and that tended to be a younger population. In Japan, for example, many of those outbreaks and clusters didn't enter into long-term living facilities, for example, where you have older people that live, people who have underlying conditions, who are at a higher risk of developing severe disease and die. So if the virus doesn't have an opportunity to enter older populations or enter vulnerable settings, then there's a greater likelihood that you won't see as much death. In some countries, we do see earlier case detection. So if you have active case finding, you have earlier case detection. If you have contacts that are being followed, if they're already in quarantine, they can prevent the virus from transmitting. But even if they develop symptoms, they could seek care earlier. So if you get early care, we know care with oxygen support. If somebody develops severe disease or critical disease requiring oxygen or ventilatory support, that saves lives. We know that using dexamethasone among the most severe patients, that can save lives. And so I think there's a lot of reasons why we are seeing differences in mortality. But a lot of it has to do with who is getting infected. We do know right now that people who are older, people who are over the age of 60, people who have underlying medical conditions like heart conditions, chronic respiratory disease, obesity, diabetes, cancer, they have a higher risk of developing severe disease and death. So if we could prevent infection in people who are of a vulnerable group, we could prevent more deaths. So I think there's a number of reasons why we see differences in mortality, but we do need to be careful about making direct comparisons because there's so many different factors.
Thank you very much, Maria. Here's a question for you, Dr. Mike Ryan, from our Twitter viewer, who is asking Dr. Ryan, is it better for every child to be tested for COVID-19 before they start school? You spoke about reopening schools a lot in previous weeks, so I think this question is coming as a follow-up to your previous responses.
Good, thanks. Just to add to the previous points by Maria in terms of why the death or the severity profile is different, and I agree with everything that Maria said. I think there is a need, as we move forward now, to be really careful about how we protect and shield those vulnerable populations, particularly those in long-term care facilities, people in detention centres, in refugee camps, in prison, anywhere where people are pushed into close proximity, and in particular people who have underlying conditions or age-related difficulties. Some countries have done reasonably better because their age profile is younger, but there is a double injustice here and we cannot escape it. It's an uncomfortable truth, but it must be said. There are many, many people in countries, because of poverty, because of their ethnicity, have much higher rates of underlying conditions because they've had historically very poor access to healthcare, very poor access to health education. They're poor, and they've not had access to the same levels of health as the rest of the population. And every country can look to itself and see where those vulnerable people have been and where they exist in society. And the second problem then is they get sicker when this disease comes, and then they don't have access to healthcare as quickly as other people. They don't have insurance, they don't have access, they live in a slum, they don't have access to good healthcare. So very often they're accessing healthcare very late, they're having to pay for that healthcare, they're impoverishing themselves in doing that, and they wait until it's too late. So there are real, I said it in my previous statement, the COVID-19 is exposing huge injustices in the way people's health is protected over their lifespan. And now, even when they get COVID-19, their access to healthcare thereafter. And that's causing a lot of preventable mortality around the world. Access to care and your previous health status and health status around the world is unfortunately very related to your social status, to your financial status, to your access to healthcare. Dr. Tedros speaks all the time about universal health coverage. We need to move to a planet in which access to healthcare is not a privilege, it is a right. Because we are paying a price right now on this planet for healthcare not being a human right. Healthcare is not a commodity. It's not a commodity to be bought and sold. It is a basic human right. And people with poor health status are doing worse in this pandemic. With regards to children and testing, I think and Maria will probably speak to this as well, it's not so much about testing children. It's about having a proper risk management approach in schools, because you could test all the children today in 2 legs, and tomorrow 3 or 4 or 5, 10 of them could turn positive and you've missed them. Because most tests right now are just testing for the RNA, for the nucleic acids, and for the presence of the virus in the nasal cavity. If they're positive today, yes, you can remove that person. If they're negative, it doesn't mean anything, because that person can become positive within a few days, especially if they've been exposed recently. So yes, testing can be part of the process of return to school, but it's not central. The most important thing for getting back to school is to get the disease down at community level. If disease transmission is low in the community, if surveillance is good in the community, if contact tracing is good in the community, if healthcare is good in the community, then the schools can go back. They're part of society, they're part of communities. It's very difficult to bring schools back in the context of intense community transmission. But even where there's low transmission, bringing schools back requires caution. And I think there are lots and lots of very good ideas out there, and schools are implementing lots of very, very smart practices, including doing partially online, face-to-face. They're cohorting kids in classrooms and not moving kids around the school. They're staggering start times and finish times. They're reducing the number of teachers, the number of pupils that a given teacher teaches in a given day. There are lots of different ways of reducing that contact, separating desks, and in some cases asking children to wear masks where that separation cannot be maintained. So there's and adding extra hand washing facilities, and then doing ongoing surveillance to pick up any children that do become positive and taking the appropriate action. It's complex, but many schools around the world and many school authorities are taking very, very clever, very innovative approaches. But it is a time of worry for parents, because parents are always concerned. I'm a parent myself, and there's nothing more worrying when you're dealing with the health of your children and should you or should you not put your kids back in school, and what are the risks. Parents need to go back to work, kids need to go back to school. We all accept this, but it has to be done in the safest possible way. And that can really only be managed ultimately at local authority level. It can be supported by government, and it should be supported by government. It should be financed, supported by government. But really, this becomes a very local process, because going back to school depends on the local epidemiology, the local transmission, the local profile of schools, the size of schools, the density of schools, the resources that schools have. And again, we're back to this issue of social justice, because it is in the very areas where we see intense transmission that we have schools that are least funded, most overcrowded, with the least number of teachers, and they're the ones that will be most at risk again. So once more, the poor and the excluded and the marginalized are the ones most at risk, even as we go back to school.
Thank you, Mike. We have a lot of questions coming around the 2 weeks quarantine. People are asking how long the virus can last in the body. Then somebody says a person was hospitalized with COVID longer than 2 weeks. So is 2 weeks still a relevant period for a person? Is it enough to be isolated?
Well, there's two things that you're talking about, Alex, and in these questions. One is how long with somebody with known infection should be isolated. And then the separate question to that is a contact of a person who has been exposed to the virus, but we don't know yet is infected. How long do they need to be quarantined? So those are two separate things. We know that people who are infected with the virus can live in the body for quite some time. It depends on the type of severity they have. If they are asymptomatic, meaning that they don't develop symptoms, it could remain in the body for a number of days, meaning that they can pass it to somebody else for a number of days. If somebody has mild infection or moderate infection, which means they have pneumonia, but they don't require hospitalization for care, and then you have people who have severe disease or critical disease, which means they need oxygen, they need to be on ventilation, much more advanced care in an intensive care unit. Those individuals, the virus can be in the body for quite a long time. We're trying to measure this in individuals, and we do that through testing. So that's different from how long somebody needs to be quarantined. If I shift my answer to somebody who's been exposed to somebody, so a contact, which means they've been exposed to the virus from somebody, the time from exposure to the virus to how long it takes for somebody to develop symptoms. On average, that's between 5 or 6 days, but it could go up to 14 days. So we recommend quarantine to be for 14 days. So that's the difference between those two.
Thank you very much, Maria. There are a lot of questions coming up on when is the right time for the person to be tested. Mike just said if you test today, it doesn't mean that there is a guarantee that you're not going to be infected and test positive in a few days. So people are asking, how do they know when is the right time to get tested?
This is a very, very good question, and it's a very difficult one because there's no one specific answer. So as I mentioned, in terms of the incubation period, when somebody develops symptoms, it depends on the policy that's in country. So WHO, we recommend that people are tested if they're in contact when they develop symptoms. If there's the possibility that countries have more testing capacity, they could test contacts who don't develop symptoms, and that could be done on a case-by-case basis. If you have a high exposure, or if you really think that they may actually be a contact and you may want to test, and you have the capacity to do so, then they can be tested. But in terms of when they should be tested after symptom onset, it's usually done after a few days. But what we know is they take an upper respiratory sample, which isn't painful. It's a little bit uncomfortable. I've had the test myself where they kind of go way quite up there in your nasal passage. It doesn't hurt, but it is a little bit awkward. Sometimes you can have a test done and you may be negative, but then they may want to test you again a couple of days later and you could be positive. And so for many people, for many cases, they may have to have repeat testing done.
So viewers are asking, in case they're positive, what is the protocol to be declared COVID-free? After how long time they should test again? And is there a recommendation from WHO how we declare people COVID-free?
So we don't use that phrase COVID-free, but we have different criteria for. The first thing that we recommend is discharge criteria from isolation, which means when do we believe that somebody is no longer infectious? So we have issued some discharge criteria for people if they are symptomatic. And what we recommend is at least, so in the beginning of the pandemic, we recommended that people needed to have 2 negative PCR tests at least 24 hours apart to be considered to be released from isolation. That is very, very challenging to do on a global level. It's very, very challenging to do when we have millions upon millions of cases and when we have testing limitations and when it takes many days to get tests back. So what we've done recently is we've issued discharge criteria without needing a test at the end. And so what our discharge criteria is for a symptomatic patient, we recommend 10 days after symptom onset plus an additional 3 days of being without fever and without respiratory symptoms. And then they can be released from isolation. For an asymptomatic case, so these are people who test positive but don't develop symptoms, we recommend 10 days from the date that they tested positive, and then they can be released from isolation.
Thank you very much, Maria. Mike, would you like to add something?
No, I think Maria got that one spot on.
There are very few interesting questions going back to contact tracing. Has the WHO issued protocols or best practices on contact tracing apps? And also, is WHO considered developing app? And also, a third question is, are we working with some digital companies to standardize those apps that are used in different countries on contact tracing?
So Mike, you want to take this one?
Yeah, no, we are. There is WHO is working with a number of Silicon Valley companies on developing COVID checkers, which will allow countries to adapt a standard app for their use. Because obviously many countries have developed apps, but other countries have not had the resources or the time. So we've worked with companies to develop a kind of a prototype app that then countries can take to adapt to their own needs. And this is through the work of both in our program, the Health Information Group, but also the Digital Health Initiative, which is led by Bernardo Mariano, one of our directors in Geneva. So there's a major collaboration going on to standardize the apps and also provide services to countries who want help with developing those apps. And there is a service there to be able to do that. We also have an increasing number of applications out there for training and for other purposes. There is a WHO information apps out there which information can be got, but we don't do contact tracing at the global level. So WHO does not collect any personalized information on individuals at a global level. It would be not useful. We collect some anonymized information on clinical cases in order to build a picture of those cases and develop therapeutic approaches, but we don't participate in the day-to-day contact tracing. So we support countries in developing those apps when and where they need them. And there's also a much broader collaboration with industry on data management systems for contact tracing. We're working with on a product called Go Data with our partners in the Global Outbreak Alert and Response Network and some industry partners on that. There are a lot of the WHO, we have a training platform, openwho.org, in which we use electronic tools for training over 4 million people now in different aspects of COVID response. And now with the WHO Academy coming online, a much bigger approach to sort of immersive learning and using artificial intelligence and other technologies for both data analysis and for learning applications. So there's a huge collaboration going on. You can speak, Alex, about the work you're doing on myth busting and the social media side of things. So IT has become a huge part, artificial intelligence, a huge part of what we're doing, and applications. But as Maria said before, these are add-ons. These are things that support contact tracing, that support authorities in doing their work. They don't replace. Modeling, artificial intelligence and apps by themselves don't get rid of COVID. But I think what we're seeing across the board is very interesting innovations that allow us to make what we do in public health much more efficient. And if there are countries out there who still need assistance and want to develop apps, both either for information or for COVID symptom checking or for contact tracing, we stand ready to support them. We currently have a pilot underway, I believe, with Nigeria and with the Nigeria CDC on adapting apps for use at national level, and I believe that will roll out to other countries as needed in the coming weeks and months.
You know, Alex, if I could just add to that, I mean, this pandemic has really forced us to use technology in new ways because we can't travel the way we used to. I mean, WHO, we have country offices in 150 countries, and we have regional offices, and we're here in Geneva in our headquarters. But WHO staff and partners, we tend to travel a lot and do trainings, but we've had to use technology in innovative and interesting ways because of the pandemic. And with the Global Outbreak Alert and Response Network, or GORN, we've actually brought together contact tracing groups and have been having these global consultations about contact tracing. What does it mean? How do we do it? How are countries implementing it? and how are countries implementing it when they're in situations where they have very few cases and when they have overwhelming transmission, when they have community transmission and it's incredibly intense. How can contact tracing be used? How can we creatively roll this out? How do we ramp up the number of contact tracers? And so there's a weekly dialogue that's now continuing to happen to share experiences. And I think one of the things that WHO does, and we tend to do this a lot with our technical networks where we put clinicians talking to one another, treating patients from all over the world and actually having them have that one-on-one distinction. We're doing that for contact tracing now, where we're bringing people together to say, this is really, really critical. How are you doing it? What are you learning? How can you help another country? Share your experience, be creative with this, use the tools that are available, but really get those boots on the ground to kind of carry this out. So it's been a great experience of listening and learning from each other on all of these different aspects. And contact tracing is another way we can share this type of information.
Thank you very much. We are running out of time and we received a lot of questions. So the one that I would like to highlight is, as we're talking about testing for the virus, etc., a lot of our viewers were asking about antibodies testing. What do we know so far? And do we have any new findings about the immunity build for people who already had COVID?
Yeah, so there's different type of testing that is done. The first is the molecular testing, which is testing for an active infection, which looks for virus part, RNA, so part of the virus in somebody. Another type of testing is looking at antibodies, which is an indication that you had been infected. You have been infected in the past. So it measures your immune response. And so there are a number of studies that are underway. There are a number of antibody tests that are available, hundreds of antibody tests that are available. Some of them perform very well, others don't perform as well. What we understand about immunity, and this is a question we get a lot, and it's a great question because it's really, really critical. For people who are infected with the SARS-CoV-2 virus, this is the virus that causes COVID-19, the name of the disease, people develop an immune response. And this takes days to weeks to develop. And what we are trying to understand is how strong that immune response is in individuals who have asymptomatic infection to people who have severe infection, and how long that immune response lasts. We do not yet have a complete picture of this. There are some studies that are ongoing that are following individuals over time, so cases that had infection and who have had an immune response, and following those individuals month after month after month. And they're measuring those antibody levels over time. And these are really important studies to carry out. So we do see some results coming back of looking at that immune response, and it looks like it in some studies that follow the same individual over time, that immune response stays steady. There are some studies that follow different individuals at different time points. It looks like it may reduce a little bit, but we don't know yet. We don't know exactly how long that immune response lasts. But I don't want to scare people. We want to let people know that, when you are infected, that you will have an immune response. We just don't know how long that will last.
Thank you very much, Maria. Mike, would you like to add something?
Yeah, no, just in between that PCR or that nucleic acid PCR testing and the antibody testing is a thing called antigen testing, which tests for viral proteins. And that's what, in some senses would allow us to, in future, to really bring diagnosis to the bedside or to the home, which is a rapid test that allows antigens of the virus to be detected. They're historically not as good at all as PCR-based testing. They are getting better, and we're working with the agency FIND, we're working with the Global Fund, we're working with the Lab Network, with Mark Perkins' group around the world to really test now how good antigen testing is becoming and seeing how we can use antigen testing with PCR-based testing to do more testing, to bring testing closer to the patient or to the person and the community. So we are beginning to innovate and see how we can use these tests together in sequence to come up with a better framework and a better process of testing. But again, the basis of testing is still testing people with suspected disease with PCR-based testing. And it is very, very effective. It's highly sensitive. It's highly specific. They're very good tests. We just need to do more of them in the right people in order to be able to make progress. But again, we're seeing a huge collaboration amongst labs around the world, between agencies around the world to scale up testing And when you think that only 7 months ago, we didn't even know what this virus was, and within weeks of that, we moved from not knowing the virus to sequencing the virus to developing tests and to within less than 4 weeks of actually finding out about this disease, we were already distributing reagents around the world in order to make the diagnosis. This is the first. This is the fastest in history. What we need to do now is scale up testing, scale up the availability of testing, and bring together the different types of tests to use them in the most efficient and the most effective way possible. Testing is still at the core of controlling this pandemic, and we need to invest even more in making it more effective, more efficient, especially getting turnaround times down. Getting test results back 3, 4, 5 days after you've been tested it just doesn't work. Those tests are practically useless from a public health point of view. So it's not just doing the testing; it's how quickly, how efficiently testing is done, and who is tested. And then does that testing result in a public health action? When someone is tested positive, what happens next? Because I've heard too many stories of people who've been tested positive, go home, they do the right thing, and then 6 days later, nobody has called them, no one has asked them about their contacts, no one has taken any action in result of that. That is a wasted test. A positive test should result in a public health action to respond to that test. That test means that individual has the disease and they may have exposed others. And a positive test result needs to result in public health action. And too often, that action is too late because the test is late or doesn't happen at all. And that's a lost opportunity to break chains of transmission and stop this virus.
Thank you very much, Dr. Mike. Thank you very much, Maria. We've been over time for today. I thank you for your efforts and for responding to all these great questions. We'll be in program again next Wednesday, and we'll talk more about mental health considerations during this outbreak. For today, I would like to invite everyone again to join us in celebrating real-life heroes, all these people who are saving our lives, saving our families and loved ones from different health threats. And please keep it with us. Follow our social media channels, our website for more information, and join us next Wednesday.
Continues to spread around the globe. You can help stop COVID-19 by participating in contact tracing. How does contact tracing work? Contact tracing is a system that has been used for decades to stop infectious diseases. A contact is anyone who has had direct physical contact or was within 1 meter for at least 15 minutes with an infected person, even if that person does not have symptoms. This applies to anyone who has had contact from 2 days before a person gets sick until 14 days afterwards, or from the 14 days when an asymptomatic case tested positive. Once you are confirmed as a contact, you will be asked to go into quarantine, which means to separate yourself from others and to monitor your health for any signs of illness. The monitoring ends on the 14th day from your last contact with the person infected with COVID-19. Quarantine can take place in a special facility outside of your home or at home if you can stay separated from family members. Why 14 days of quarantine? It can take from 1 to 14 days from contact with the virus to develop symptoms. During this time, you should stay in quarantine and monitor symptoms and follow instructions given to you if you become symptomatic. Without contact tracing and quarantine, the virus will